Welcome back. We're starting the new year off right with another episode of Everything is Public Health. I'm one of the co-hosts, Big Murray. We got the other co-host, the Honorable Dr. Linda Ray Murray. We got two special doctor dentists on our podcast today. Today we're going to be talking about dentistry, what Black folks need, what are they doing, and they'll provide us with some nice suggestions. So before we get started, Dr. Murray, would you like to say anything?
Yes, certainly. This is an important day. As you know, the attempted coup by these crazy white supremacists was defeated, and
it wasn't all white folks out there, but it was a lot. But go ahead, I apologize.
But the ideology was white supremacists, whether they were Black people or other people out there. And so I just want to do a shout out for our new president. Not my first choice, but that's okay. He's not Trump. That's a good thing. And I especially want to raise up our sister Kamala Harris, representing HBCUs, Howard University. I should say, for those of you that are into the sororities, an AKA member in good standing. So that's something for us to be proud of. But I think actually today, the inauguration, allows us to think about in this podcast what we need to do going forward. We've had inaugurations before. And so the real question is, what do we as a people need to do to try to get us out of the holes that we're in and the situation we're in? So I'm looking forward to this conversation. I just want to also, just since I'm old, I also want to just say something about Black dentists. Dentistry is started later in America's history than medicine. And I think Harvard was the first dental school in the United States in 1870, right after the Civil War. But Howard opened its dental school in 1881, and Meharry opened its dental school in 1886. And they still have produced a huge number of Black dentists that exist in the country. So just like we focus often on how few Black doctors we have, and certainly that's a shame, but we also have very few Black dentists. I think it's under 4% or 5%. My colleagues may have more up-to-date information. And I know for me personally, let me just speak as a 72-year-old Black woman. When I was a little girl, we never went to the dentist unless we had a toothache, unless something had to be pulled. And that sort of followed all the way through most of my life. And so dental care is still in this country very much of a luxury. And I guess that's my real question here. What is it really a luxury? Well, it is, because you can't afford it. But the point I'm trying to make is, should it be a luxury? And what can we do to let people understand the mouth and teeth are really part of the human body?
Excellent point. So let's start with introductions. Dr. Williams, tell us a little about yourself. You're muted too.
Yes. Hi, I am Dr. Williams, Dr. Jessica Williams. I graduated from Howard University, so yay, in 2014. Graduated from University of Illinois Chicago College of Dentistry. Very lucky to have Dr. Smith as a professor and mentor there. And I graduated in 2018. Now I'm a National Health Service Corps scholar, and I'm practicing in rural Iowa at a FQHC. And I'm originally from north of Chicago.
Excellent. Mm-hmm. Doc Smith.
Yeah, Patrick Smith. Went to Morehouse College, graduated dental school this is 14 years from me, from Harvard School of Dental Medicine. Been in Chicago ever since then. Had a practice in Hyde Park on the South Side for about 9.5 years before transitioning full-time into academia at UIC. So my focus is actually public health dentistry. So I'm at the university trying to, encourage students to go into public health careers and to really think about the larger systematic issues, that Dr. Murray talked about, in regards to access to care.
So Dr. Murray brought up a good point. She said she didn't go to the dentist unless she had a toothache. That's usually the stigma or the characteristics of how we treat dentists in the Black community. So I didn't go to the dentist unless I had a toothache. I actually not very fond of dentists, and that attitude has probably caused my children to have the same thing. So is dentistry a luxury? Like, what's going on with Black folks and coming to the dentist from your perspective?
I mean, I can jump out there. I mean, for me, a lot of it is we don't have the information. We don't know necessarily. And then, of course, obviously, when I say we, I'm not talking about all Black people, but, you know, from the experiences that I've had, a lot of times we don't really know how bad it is, right? Until it's really bad, until we actually start to feel something, which is usually painful or sore. You know, so there's some misinformation out there about when we should go, about how frequent we should go, about what happens when we get there, even where to go. I mean, it's amazing. A lot of people really, you know, if you walk down the street in Chicago, you'll see a dental office on every corner, right? But people still have questions about, you know, whether or not that's the right place to go, or they accept my insurance, or, you know, what's the energy like? Is the doc good, right? So there's perhaps some trust issues there as well that, you know, perhaps hold people back from really committing to finding out where they can go to get care.
Mm-hmm. Absolutely. Touching on is dentistry a luxury? I feel like it's multifactorial, and I think a lot of it has to do with society and the media and how we treat teeth. When people are watching TV and they see a Colgate commercial, a Crest commercial, it's about bright teeth, but it's not about functional teeth, or, you know, are you able to chew with those teeth? It's just, are your teeth white? Are your teeth straight? And so that's why when, like Dr. Smith was saying, it's not just Black people, and I can definitely confirm that, working with mostly rural, low-income white people, that it really is a conversation. It has to do with really society and the value that we place on dentistry and teeth. And I think that one, it's the media, but also I think that dentists don't really help change that perspective either. We don't say, hey, it's not just about white teeth. It's not just about straight teeth. A lot of us aren't really having that conversation. And so I think just within the dental field, we need to have a conversation amongst ourselves on how do we promote good oral health? What can we tell patients? What can we tell the public that is representative of good oral health? Is it white teeth? Is it straight teeth? Or again, is it, not having bleeding gums? Is it loose teeth? What does that mean? Is that a sign of poor oral health, or is it just because your teeth are maybe a little bit crooked? Does that mean that you have poor oral health? So I think we really do have to ask a lot. We have to ask a lot of questions externally of the media, and then we also have to ask questions internally as a field. What are we promoting as good oral health?
One thing that always struck me working over my career is that in Cook County Jail, prisoners are the only people in this country with a legal right to health care. Actually, which is ironic. And so in Cook County Jail, a lot of times with the people that are incarcerated there, that's the first time they've seen a dentist in their life. And a number of them, unfortunately, are there long enough to get a whole series of work done. And so that's one of, certainly within the county system, like with all of our services, the jail is one of our high priorities to try to make sure that those services are never compromised. But to me, so I'm a physician, and I've had good health insurance, and I paid for dental insurance, none of which was very good. So to me, that's sort of where it starts. So that even if you have a job, if you have good health insurance, if you think you ought to go to the doctor, for a pap smear, or for, checking your sugar, or for a prostate exam, the notion of going to a dentist is not at the same level. And part of it is because it's not covered by the insurance. It's a different insurance. And frankly, most of the policies I've seen are very, very, very inferior. Even though Mr. Murray says he never went to the dentist, I remember paying for a bunch of braces for you that the insurance didn't cover.
And that's a good point, because that had a bad experience for me. Dr. Greenfield off 87th and Stone, good cat, but that cat used to put me through hell. So going there, I definitely didn't want to go to the dentist anymore. I definitely don't like male dentists. Their hands are too big and they try to be too tough. Like seeking out dental care is crucial. Like Dr. Smith said something about what you see in the neighborhood. What I see in my neighborhood, and it's a nice neighborhood, South Shore, these dental offices don't even look clean, man, from the outside. The names on the doors I can't pronounce, so I definitely don't want to go in there. And then the cost factor, even if I want to deal with that, especially when it comes to my children, it's about finding people you trust. And unfortunately, it's not that many that look like me. You know, I'm not opposed to seeking healthcare services from other people. I just prefer to, you know, deal with somebody that looks like me, and preferably a woman if she's a dentist. You know, no offense, Pat. You know, but I would definitely send people to you. You know what I'm saying? I just, you know, you a big dude, Jack. I don't want them big hands in my mouth.
Yeah. So, you mean, as you guys are saying, it's like when you walk in Chicago or any really urban area, you'll see a dentist, like you said, on every corner, and maybe not even on every corner, maybe like a couple on one block. But, you know, is that still accessible? And that's just crazy to me when you think of like, oh, you know, people can't go to the dentist because it's a dental desert. But no, in urban areas, it's not a dental desert. There are dentists everywhere. But what makes it a desert is a lack of access to actually being able to afford the care. That's what a large barrier is. And that's what's so unfortunate.
Yeah, it's really crazy, Marcus, because I have a lot of questions for my profession, just being quite honest and frank with it. You know, and when we look at how dentistry is somewhat, you know, it's a self-regulating profession, right? I can wake up tomorrow morning, rent out, you know, 1,000 square feet, put a dental chair in it and get busy. And nobody's going to tell me anything, right? Mm-hmm. I can do what I want, right? So, you know, from that standpoint, you know, the question is, you know, like Jessica's point, and even to your point, right? What's the level of appropriateness, you know, for providing service to a community when, you know, you don't necessarily have to make your services available to that community. You could just be in that community for whatever reason. You can charge whatever you want, right? The coverage is not anywhere near what it should be. And this is public insurance, especially public insurance, like Medicaid. Medicare doesn't provide anything. Private insurance, you know, you're lucky if you can get $1,500. And even with that, the cost share is 50%. Right. Mm-hmm. So, you know, if you come into my office and I say, you know, I'm gonna do $1,000 worth of work and I'm gonna charge you $500 cash, take it or leave it. A lot of people choose to leave it.
Mm-hmm. Mm-hmm.
You know?
And when you, go ahead. And when you talk to private practice dentists who maybe don't take as many Medicaid patients, a lot of them will tell you it's just about reimbursement. Yeah, like maybe I would take some, but you know, it's the reimbursement is really, really dismal. And so a lot of people do talk about that as being the reason why they don't take as many Medicaid patients. But it also does, let's be honest, have to do with sometimes I've heard dentists saying that they don't quite like working with that population, or they only have certain days that they take Medicaid patients. And so they have them only there on that day just because maybe the culture is a little bit different. So, you know, we also need to be honest and have that conversation of, okay, well, let's say the reimbursement rate was great. Would you still take that population? Yeah. Yes or no?
That's
well, you know, in some parts of the world, this isn't an issue, but certainly so for example, in Canada, you either participate in the program or you get nobody. Okay, so that's one big thing. And so I know we're talking about dentistry, but this is an opportunity for me to say clearly, I think Black people, we need to be more wise as to what policy questions we're talking about. And we need to understand that we live in a country, well, it ought to be obvious to everybody now with COVID-19 running rampant. We live in a country that does not have anywhere close to the best medical care system in the world. That's just not true. And there's no reason that people should have to pay this amount of money. There's no reason why we should be separating where one gets one care. I, for example, would feel more comfortable in our FQHCs, where at least you're going to your physical care doctor, and many of our FQHCs now, our community health centers, have dental services right there in the center. Everything's together. That's so important. So I think that that some of the problems we have are policy problems. If we had real health care, Medicare for all, that included dentistry, behavioral health, I mean, think about the things that get limited. You know, if you have a teenager going crazy, which is like every teenager, you know, there's a limited number of sessions you can go to in your insurance. You know, I'm an old person. There's a limited number of physical therapy sessions that I can go to in a given year. So all that kind of nonsense we need to get rid of. And one of the first things that I would say for any person, and especially health professionals, looking at changes in our healthcare system, we have to have parity, equal status for physical health, mental health, and behavioral health, and dentistry. Don't let me leave out podiatry. All of these modems of healing that we use in this country, they need to be put on an equal footing, and they need to be supported. So you don't have to pay at the point of service. Pay for during your regular taxes, okay? But not when you need care. That's not where you should be paying money for these services. So to me, that's the biggest problem we have.
So let me ask this question, and Doc and Dennis, all the docs. You all mentioned that there's kind of a disconnect between the medical field and the dental field. So Doc Murray, have you ever came across one of your patients that you figured might need dental services and not express, or do you even talk about dental services during your sessions with patients? Because people would listen to you. Do you even have time? Does it come up? Is there a connection there?
So the answer to your question first is yes, I have plenty of patients who needed dental services. Was I as proactive as I should have been? Now, don't forget, I was an internal medicine doctor, which meant I took care of adults, and for all the reasons we know of, they tended to be older adults who did need dental services. So not as much as we should. You know, I would always examine the mouth and all that kind of stuff. So at least I did that. But I did not emphasize routine visits to the dentist. For people who clearly needed care, which was a lot of people, probably the majority of patients that I saw, I would try to I would ask them, you know, have you seen, so if I saw a cavity in the mouth or something, I would ask, do you have a dentist? Have you seen a dentist? And more times than not, the answer would be no, or I saw a dentist 5 years ago or something like that. And then frequently the patient would say, I can't afford to go to the dentist. And we had a list in the county system. Getting into our dentist was very, 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 very hard, but I would explain to them how to try. We used to open up the phones at 7, and by 7:15 or 7:20, all the slots would be gone. Okay, so, and then we had a list of free or very low cost dentists in the Chicago area that we would give out to the patients. You know, we just a list of names, but it's not enough. It's not enough to meet the need. I will say this, there's some leadership, I hate to say it this way, but it's true. There's some leadership that's no longer with the county, but over my years, their attitude was, we don't want to put too many dentists. We don't want to hire a whole bunch of dentists, because my position was, we need to hire more dentists. They said, no, because we can't meet the need. And if we hire more dentists, then we'll have more patients that come for the need. So they were clear that the need was so great among poor people. When you look at somebody's, my father used to tell me, you could look at somebody's mouth and look at their shoes and get an idea how much money, how much resources they had, you know, because getting dental care is expensive. And I guess in his mind, having a good pair of shoes was expensive too. So, so that's really a problem. It does cause significant morbidity and mortality that people don't even realize. It complicates a number of physical problems, cardiac problems, and other things. And there's no reason to walk around. Imagine walking around with dental pain for years, and that's what people do. So I think this is, to me, if I had to pick one thing that I would want changed, it would be not having that parity. Obamacare did not do it because it was considered too expensive, and we just have to insist on it.
So, Dr. Williams, you had mentioned about messages that we need to get out there just for options for people to understand what it's like. Do you have any suggestions?
As in messages of how we
Importance.
about the importance of oral health. Yeah, absolutely.
Right, as opposed to just white teeth. Like some simple things that we can share with people.
Really, it has to do with talking about preventative visits and talking about, again, encouraging flossing, brushing. All of those things can help you keep your teeth functional. And if we talk about how function is really important, how we want to be able to chew correctly, how we want to
what is chewing correctly?
What is what correctly?
What is chewing correctly? What does that mean?
What is chewing correctly? So when people lose their teeth, they're not really able to chew. So kind of how Dr. Murray was saying, it really does. And when you have poor dental health, it really does impact your whole body. Just because think about it, you're not able to eat carrots or you're not able to eat celery. You have to eat a soft diet, which are primarily very highly refined carbs. And so that it just creates this downward slope of poor oral health. And so if we talk about how oral health is connected to the overall body, I think that's the first step. And then the second step is, again, preventative visits and talking to your dentist. And also, but like I said, it's also something that dentists have to talk to amongst themselves about what are we promoting in the chair? What are we focusing on for the patient when they're in our chair? Are we focusing on, oh, your smile is a little off, or the midline is a little off? Or are we talking about, hey, your periodontal pockets are really deep. You look like you have gum disease. Your gums are really inflamed. So what are the conversations that the dentist, the dental hygienist are having in the chair with the patient? And then we also need to promote those messages outside of the dental chair. So like I said, when we talk about maybe commercials or public appearances, what are we focusing on? Again, are we focusing on the bright smile, or are we focusing on, you want to make sure that your teeth aren't loose and that they aren't, wiggling around. You want to make sure that you're not you're not grinding your teeth and causing fractures. So there are some conversations. There are some ways that we can shift the conversation from, again, straight pearly whites to talking more so about function.
So Dr. Smith, to piggyback on what Dr. Williams said, so basically she's talking about some type of form of research to create these culturally specific messages for Black folks, rural folks, or whatever. What's going on with research in the dental world with Black folks that you know of?
Nothing. No, I say that jokingly, man. But, I think where we are in dentistry, man, is really trying to figure out what are the barriers that people have to get into care. Like what's really behind people not utilizing the system. Right. There's a lot of, we make assumptions and we speculate that it's about affordability or, but say like racism and oral health or discrimination. Right. I mean, we're just now getting into those conversations in oral health and dentistry. Right. To say that, yeah, people don't go because they've experienced discrimination or, the other thing that I try to focus on in my research is building this or understanding more, because I'm in it to learn about.
What type of research do you do?
Well, we got a couple of things we're working on. One, we did some surveys with Black men, right, to try to get a sense of two things. Well, really three things. One was quality of life, kind of like what Jessica talked about, asking those questions like, what matters to you and how does this affect your daily life, right? Is it a function? Do you want to look good? What is it about your teeth that is motivational for you to take care of them? And what hinders your lifestyle when your teeth are not right? The other question was dealing with social context, which is really what's going on with you, man. What's going on in your life? Do you feel like you're financially secure? Are the kids okay? You know what I mean? Is the job situation okay? Let's really talk about these things and see, are those things impacting your health? And the other question was about social adjustment. So this is not just the bad adjustments that talk about like, oh yeah, I got a traffic ticket, so that messed my head up. And, perhaps if these things keep happening to me, right, over the course of a year, then that's going to have some impact on my health. But the good things too, right? Maybe I got married, right? Maybe I got a new job, right? A better situation. So are some of these things protective and motivational for people to take care of it? So we're asking all of these questions. And, you know, we're getting somewhere with some of our results to really get a sense of, you know, and it's really just for understanding at this point, you know, to try to get a sense of where the need is, you know, what are some of the motivators that people might have and demotivators for going to the dentist.
Do you have any preliminary results that you could share real quick?
Well, yeah, the preliminary results, the biggest results are essentially the things we've already talked about, right? You know, the people who don't have insurance don't go, right? The people who do have insurance utilize it. Now, granted, this is higher income. As income increases, you know, your likelihood of going to the dentist will also increase. Men who smoke tend to have, at least from our data, that have a higher need and utilize services less, right? So again, kind of get into that another question is why are you smoking, right? What are the motivations that keep you lighting up a cigarette every day, and what could get you to stop smoking, and will that impact the way you think about your health or vice versa? So those are the big highlights that we're focusing on right now.
Let me ask.
Go ahead, Doc.
I was going to ask a question about fear. I don't know if this is still true, but I remember when I was in school, medical school, dentists had one of the highest rates of suicide. And what we were told, I don't know, was that people fear them, just like Marcus. You know, certainly, I tell you, I am a basket case when I have to go to the dentist. You know, there's no question, and it's irrational. Especially for me, it's irrational. But we have all the cultural things that are out of date. You know, where they're making jokes and you're pulling out a tooth and all that. So we have those sort of ridiculous things that are no longer true and haven't been true for some time. But nonetheless, you know, I do remember when I was little going to the dentist, and I remember being afraid about it. And you know, you have someone right in your face, right, working in, you know, so it's in terms of sort of our personal space and how we function as human beings. You know, think about who is allowed to even touch your mouth. Let's go inside your mouth. You usually are talking about an intimate partner. You know, it's what you're usually talking about.
Right.
So how do we address this and should we begin to address it more head on? What is really a fear factor, say for people who could afford some preventive care or could afford, you know, some basic care.
Absolutely. And there are definitely studies that show that even if they can't afford care, if they still didn't go, fear is a huge reason. And fear, an event could have happened as a child and it will carry them until they're 75. I had older people in my chair who say, I haven't been to the dentist in 20 years because I had a terrible experience when I was 5 years old. And that stays with you. But I think it all comes down to bedside manner. But when you're talking about low-income clinics, that's where it's even more so important to have bedside manner and to really treat the patient like they're the star, like you're rolling out the red carpet for them, because they're not used. A lot of people aren't used to that treatment in a clinic or in a low-income clinic. So to be able to listen to them, and I give them the time and I give them the space to tell me what happened. If they tell me, oh, I had a bad experience, I go into it. I say, okay, well, what happened? And I listen to what happened, listen to their fears, and try to figure out, okay, how can I make this experience better for you? And so it really does take us having to take a little bit more time out, not immediately jumping in your mouth. Because like you said, it's a very intimate space. It's a very intimidating situation to be in when you're like laying back and somebody's hovering over you. And then like they got these sharp tools and needles. And then you have the conversations in society left and right talking about how, you know, this experience is so painful, yanking teeth. It's just, again, the way that the media portrays dentists, not in a very good light. So then, of course, when you get in the chair, it's just I can understand how it's a very terrifying experience. And if you have poor oral health, that means that you're probably getting extractions, you're probably getting root canals, you're getting treatments that isn't just a basic cleaning and just, okay, see you in 6 months. It's like when they've avoided the dentist for that long, haven't been taking care of their teeth, and they were also scared of the dentist, when they get in the chair, it's like when we have to do, again, multiple surgical extractions, that just makes things worse. And so again, with those patients who have that level of fear, I do take the time out to stop and to be like, okay, what happened? What was your experience? Sometimes they just say, oh, the dentist was mean, or like Murray, you were saying the dentist's hands were too big. So he's like, so I think we'll be okay with you. I'm like, okay, well, that was easy, but others people's fears aren't so easy to address. So just really listening to the patient, but that takes time, and that takes time out of your schedule, and that takes up money. So, then you're talking about the higher administration and policy. And so it's really all very much so connected, but sometimes so that's why, again, it's like maybe we just have to rework the system into making it so we can take that time out to address these people's fears.
So I just got a question. I do want to say, I want to give a shout out to my dentist, Dr. Watson, on 84th and Stony. It's a female. She inherited the business from her father. If it wasn't a woman, I wouldn't be there. I'm telling you right now. And I still don't go as much as I need to, but I do want to give her a nice plug. And coming down the line next month, folks, we're going to let people call in, so I won't have to look at my phone all the time to take these questions. Somebody asked, what can we do to increase the number of Black dentists in the field? And is that a factor in Black folks seeking care, dental care?
Well, can I just speak from my personal experience? Maybe
let me ask you all this before we get started. How many Black dentists graduate from dental school a year, from an estimate that you all know about? Do you know?
Every dental school is a little bit different. So, like, if you're talking about Howard or Meharry, of course, you're looking at a big number of people. Whereas if you're talking about maybe a private school, 1, 0, some schools 0.
I mean, in the country, if you take out Howard, and Meharry, and we should have more. That's just a damn shame we only have 2. Like, are there 1,000? 500 Black dentists that graduate a year? 100, 200?
I might have to get back to you on that exact number.
Okay, no pressure. That was a trick question. So what can we do to increase Negroes getting into dentistry? Like, these little 12-year-old, 15-year-old kids, what's the thrill of being a dentist?
Absolutely. So one, getting kids into the dental chair. So what you find is that even though kids may have coverage, they're still not getting their preventative visits. They're still not going to the dentist. And then, like you said, they're going to the dentist when they only probably have a problem. So that obviously makes you not want to be a dentist. But also the conversations about careers. When you ask a kid, what do you want to be when you grow up? Doctor, firefighter, cop. So there are just some careers that, kids always kind of have their minds on. And when you're talking about smart Black children, the conversation a lot with them is, oh, you're going to be a doctor because you're smart and you're good at science, or you're going to be a lawyer because you're good, at writing and debating. So it's like, I feel like when we talk to our children about careers, a lot of times we're really honing in on only a couple of things. Like, okay, if you're smart, you're educated, you're going to be a doctor, or you're going to be a lawyer, or, maybe engineering. And a few more people are talking about engineering now, but I didn't really consider dentistry until I got to college. And so I had said for a long time that I wanted to be a doctor. People are like, oh, you're smart. You get science, you get math, like doctor. So I'm like, yeah, doctor, that's it. And it didn't even cross my mind that I could be a dentist until somebody said, hey,
so what changed your mind?
Somebody said, hey, you need to consider dentistry. That's what it. Now, I didn't convert right away because I felt like, I'll tell you what I felt like. I felt like he was trying to tell me that I couldn't be a doctor. And I felt like a dentist was below a doctor. Because again, the way that we talk about doctors in the community, it's like, again, if you're smart and you're really trying to have a lucrative, seemingly lucrative career, that's the doctor, right? And so I'm thinking, no, like, I don't want to be a dentist. I want to be a doctor. And he's like, no. He was like, seriously. He's like, look into dentistry. He's like, it's a great field. You are a woman too. It's a great field for women too. He's like, I swear, just give it a chance. And just because I gave it a chance and had an open mind and somebody brought it up, that's the reason why I ended up going to dentistry, is because I had an open mind and I started researching, I started shadowing, I started doing community health events, and I realized how important teeth were to the entire body. And I just really saw dentistry as the underdog. And so that's why I really am a champion for increasing diversity in dentistry, really trying to participate and help with pipeline programs like, so it used to be called SMDP, SHPEP now. And so really trying to encourage students to, and if they, but we also have to be careful of not pushing kids. Like I said, pushing being a doctor on a kid either, but just letting them know, like, this is what it would be like if you decide to pursue this field. This is how we can help you. This is what you need to learn. And really just letting kids know that you have options, and dentistry is one of those options.
So Dr. Smith, at UIC, if I'm a senior in college and I want to get into dental school, what's the process? Like, what exams do I need to take? How does it work? Because I don't even know. People don't talk about that process.
Yeah, well, if you're a senior and you're making that decision, you're already a little bit behind the eight ball. Essentially, there's some core courses that you have to take in order to be eligible to get into a dental school, right? You got to take the chemistries and the physics and all the biology classes. You got to take the calculus classes. So that's number one. Your science GPA also has to measure up. It's competitive out there. I think to be competitive at UIC as a Black student, I would say you need at least a 3.5 science GPA, right? I got a friend of mine who said, don't let the referees get involved, right? So you do what you have to do to get your 3.5 on as best you can. After that, you have to take an admissions test. So, like in medical school, they have the MCAT, law school has the LSAT, dental school has the DAT, the dental admission test. So you take that exam, the national average is usually about 17, right? So aim for higher than that with a 3.5 science GPA, 3.5 cumulative GPA, and you should be in good shape to get in somewhere,
So let me ask you this. Besides that, what can you compare that DAT to? A GRE, a MCAT? Like, what if you had to compare, like, from peers that might have taken both? Like, is it hard? Is it stressful?
It's kind of its own monster. To be honest with you, it's not quite like any of the others, if I'm being honest. You have an organic chemistry section, a general biology section. I think there's a math section, and then there's a section that they call perceptual ability, which is really different than any other exam because they want to see, they'll basically give you a shape and they'll say, which of these shapes can fit into this box, right? And that's a whole section of the exam, is they're giving you these questions where you have to use sort of, 3D conceptual ability in order to understand how things are shaped and what they call depth perception, so that's a big part of the test. And I think most people tend to do well on that because that can be trained. You're just training your eye, that can be studied. I will say the DAT scores for our Black students, at least the ones that I have mentored over the years, tend to be on the low side. I really don't know what's that about. I have a young man that I've been mentoring for the last couple years. And like I said, if I say the national average is 17, he's taking this exam maybe 3 times and he can't get above a 16, and as more time passes, you see, he's out of school, he's out of college already. So they also don't really look very favorably on that. If you've been out of school for 2 and 3 years away from these science classes, and now your DAT score is not quite measuring up, it becomes harder and harder for you to get in. So I would say if you, start thinking about, I'm fortunate. I went to Morehouse College where we had a dean of health professions who didn't play that. If you came in and you even thought, if you had a 2% idea in your mind that you were going to go into a health profession, he put you on the program, right? He wrote your schedule out for those 4 years. He told you exactly what you was going to take. when you were going to take it and what grade you needed to make in that class in order to get to where you at least would be in the conversation by your junior year when you started applying. So, a lot of the guesswork and the initiative was, I didn't have to think about that. I just had to go along with the flow. A lot of these kids don't have that. And so by the time they get this information, it's late in the game.
Mm-hmm. It's late. Yep. And they haven't had time to prepare. And I'm going to say a big thing is finances. It was expensive applying to dental school. Like if I didn't have, my mom to help me and, if I wasn't saving up, if I hadn't, had scholarships and stuff, like this would have been so much more difficult. I was blessed to have a scholarship that paid for my Kaplan course and that paid for my DAT materials because I was looking at it from what I wanted. So I did research on the best materials out there and I wrote out the cost and I'm looking at like $3,000 and that's just to take the test. That's not even to take the test. Wait, that's to prepare to take the test. And then when you're applying to dental school, I think that probably cost me about $1,000 something to apply to dental school. Right. And I'm a college. And yes. And I'm a college student. And I'm a college student. And I was lucky, like I said, I was lucky enough to have scholarships. But why did I have scholarships? It's because my grades were good in college and their grades were good in high school. So a lot of this starts very young. And that's what people also aren't talking about is how are we investing in our children when they're 10 years old, when they're 15 years old? What are we encouraging them to do? How are we encouraging study habits? How are we encouraging applying for scholarships? Because all of that, all the reason why I'm here is because of some things that have happened probably when I was in middle school or high school and the way my life worked out. And like I said, finances is a huge factor in that because I mean, you could be smart, but if you can't afford to you can't apply to a dental school, you can't afford to take the test. And if you can't use the best materials, how are you going to challenge this test? Because a lot of these tests are just about learning the test. It's not about the actual material on the test. And it's like, if you have a program that tells you this section is 50 minutes, so you want to pace yourself to make sure that you spend 15, so that's what those programs do. They tell you exactly the breakdown of the test, how it's structured. They give you recommendations on how much time you should be spending on each section and what to do if you find yourself in a bind. All of those things have nothing to do with organic chemistry, nothing to do with chemistry. Has to do with learning the test. And if you don't have those resources and if you don't have those tips and tricks, you're not going to do well on that test. Most likely.
Go ahead, Doc.
I was going to say, so all of our pipeline programs that are geared toward getting young people who are interested in healthcare and preparing them to be competitive candidates, those are critically important. But in my mind, we have to step up even more than that. So it's just like basketball or anything else. If you didn't have a basketball hoop somewhere in all neighborhoods and stuff, you wouldn't get NBA players. The wider you spread your net, the better chance you have of getting people. So we for example, in CPS, you cannot take science. You can't take 4 years of science in every high school in CPS. Now I went to school. I was born and raised in Cleveland. Everybody who graduated from Cleveland Public High School, even people who knew they were going to go become a plumber, took 4 years of science. It might be the science of, if you went into carpentry, you would take the science of wood, okay, but you would take 4 years of science and 4 years of math. So one of the problems is that our educational standards have gone down, and we act as though we can just sort of look at a bunch of seventh graders and say, you're going to be a doctor, you're going to be a lawyer. And then we put all the resources on those kids. Yeah. Right. It's better than no resources, but that's not enough. Yeah. So there, as we all know, there are people who stay to be knuckleheads till they're 21. They don't wake up until those people could still be doctors and dentists if we had the right attitude. Right. So that's the first thing. The second thing is a lot of things we put in front of students, and let me speak here for physicians. I don't want to insult, I'm not trying to insult anybody, but I'm gonna tell you, organic chemistry has relatively little to do. I'm not saying people shouldn't take it with being a functional, competent, good physician. So our notion, the barriers we have are not related to what you need to practice or do research or a number of other things.
Yeah.
For example, what I would love to see with the MCATs is three scores. You're ready to successfully complete medical school. Completing medical school for you might be somewhat of a challenge. You may need help. You're not ready to success. I would just like those 3 scores. That's it. Because what schools do is they'll act as though like this young man that you mentioned that has a 16 instead of a 18. Well, I'm gonna tell you, I don't believe that 16 and 18 is going to make or break him in dental school. So we should stop pretending it is.
Yeah.
So the second thing I wanted to ask you all about. I know one time I was in Alaska in the Native American communities, our indigenous communities there, and of course, in addition to being the original people of color on the continent, and being far up in Alaska, they are not. There are very few, even fewer Native American doctors and dentists than Black. And so one of the things when I was in Alaska, they own. They're a separate nation, so they had their own health systems, and they had a huge number of what we would call in this country mid-level dental and physician, but mid-level dental providers. Because then not only is it a problem of where you get educated, there's no dental school in Alaska. You have to go, as they say, to the lower 48 to even go to school. Okay, so there I was able to see a clinic that looked very much like our FQHCs, but a native clinic run by the community where they had dentists, but they also had a huge number of mid-level dental providers that functioned at a higher level than our mid-levels do here. And so ignoring the problem, now here I want to be clear, I think mid-level providers play an important role in healthcare. I believe in a team. That doesn't mean we should be relegated to mid-levels, so don't misunderstand me. We should have people up and down the line. But to what extent could mid-level providers help address some of the things that we're talking about, fear, cost, and other issues in terms of providing dental care for our community?
Yeah, this is interesting. This is a extremely, extremely volatile topic in dentistry. Because again, you have a lot of people in this profession who see a mid-level provider as a threat to their business, right? Me personally, I feel as though anybody who wants to jump in, should be able to have an opportunity to jump in. When you look at the scope of practice right now, they have what they call dental therapists, practicing in Alaska, practicing in Minnesota. There's about 8 or 9 other states who have passed legislation that allows dental therapists to practice within that state. Now, one of the issues is getting licensed as a dental therapist, meaning they have to go through some sort of educational training program, and those don't exist in abundance yet, right? But I think there are a lot of people who are starting to see the value of a mid-level provider, particularly when you look at what Jessica was mentioning earlier, right? People who, these communities where the dental service is not available to them. Well, perhaps a mid-level provider can jump in and make it more available, can make it more accessible. But again, that's a huge policy debate. I was at a meeting once, and somebody from the Illinois State Dental Society stood up and slammed on the table and said, "We do not want those people in our state," right? Like we don't want them in Illinois, send them to Indiana or somewhere else, So that's going to be an uphill climb. I think for me, what it comes down to is this, and you already said it, Dr. Murray, the barriers to entry. If you're willing to say that you can I say this because a lot of the training that the mid-level providers get is literally in the very next chair aside a dental student in Minnesota, right? Like literally.
Absolutely, yeah.
They sit in the exact same classroom. So if you mean to tell me that I can get into school to become a dental therapist, but not a dentist, and learn the exact same thing that you're learning minus a couple classes. Let's be real about what the average general dentist is doing every day. That's another thing I need my general dentist to stop lying to themselves about the importance of the work that we do. Absolutely. I can say this because I'm a licensed dentist. We do the easy stuff. We do the profitable stuff. We're not in there reconstructing jaws and stuff like that. You got a small section of dentists who actually practice at that level. Most of us are drilling and filling. Let's be real about it. So what I see is that if you're going to tell me that a student has to get an 18 on the DAT and take organic chemistry and be this brilliant, bright, superstar and have all the things lined up, volunteer service and grandfather was a dentist and all this other stuff, they can be a dentist, right? But the kid who made a 16 can be a dental therapist, right? When there's really not much difference between those two students in terms of what you're going to teach them. You're going to teach them the same thing, right? So I think if we could sit here and say that we can acknowledge a dental therapist, then I think we also have to acknowledge the barrier to entry for someone becoming an actual dentist, right? And why does that barrier exist?
You said it earlier. It's a deliberately designed economic barrier.
Yeah.
And so in medicine, physicians have, I think we've lost the battle, which I think in the long run will help people. So we have mid-levels in so many different areas now. Dentistry, not yet, but it will come, I think. And what we need to make sure of as ordinary people in the country is that people get trained to do the scope of practice they're going to do. I don't like hiring a physician's assistant just because I can pay him less than a doctor. When for treating high blood pressure and simple diabetes, they're doing the same thing. So I agree. We don't want to falsify differences that should not exist. So I don't want, and this is what we've seen in nursing, for example. For years we saw, and we still see it today, to be honest with you, certified nursing assistants. We used to see LP, licensed practical nurses, would be more heavily Black than RNs. And this wasn't because they were doing anything profoundly different. It's because of the barriers to training and the barriers to licensure. So,
and so that's why I say that dentists amongst ourselves really need to figure out what we want dentistry to be, what we want oral health care delivery systems to be, because a lot of those are conversations, like Dr. Smith was saying, is that we have arguments that we have amongst ourselves. And so a lot of that maybe if we talk about policies, maybe if they just make us, do this a certain way, but we also have a lot of leverage when it comes to policy and advocacy as well. So I think it's a conversation that we really need to have amongst ourselves, but that conversation can get pretty hairy because it really means changing the historical view of what dentistry is and what it used to be. It used to be a surgical field, doctor of dental surgery, mostly just about hands and about the art form. So we really have to think, and mostly majority, like most fields, majority, white male. So it's like we have to think about, what do we want dentistry to be in 2021? What do we want oral healthcare to be? What do we want those oral health delivery systems to look like? Are we okay?
So to me, go ahead, Doc.
What about these huge companies that advertise on TV where you can come in? I had some dental implants. It was I won't bore you with the traumatic experience as well as the financial cost of such a thing. But so I just sit up there and they say, you can come in and out in one day. And I'm saying, like, in what universe? So we have basically, they shouldn't be allowed to lie like that on television. But what impact do these huge corporate dental practices have on the field? And what does that mean for the role of Black and other dentists of color?
Yeah. Well, it has huge implications in terms of access to care, access to a dental career. Because traditionally dentistry has prided itself on its autonomy, right? Again, I can get a license, I can go down the street, and I can get busy, and nobody's going to think anything of it. When you have corporations who come in the mix, a lot of whom are non-dentists, then it becomes even more of a business model, right? So it could go a couple different ways. It could work for the people if the prices go down. Right. So if they get so big and they start competing with each other to the point where now the competition is to see who can offer the best treatment at the lowest price. Right. Then I say the community wins. in that situation. But it could also go the other way, right? Because now, you know, the large corporations, as we see in America every day, they control the price, right? So the price can easily go up, especially when you're dealing with a cash paying industry that has enough cash to lobby for the policies that will benefit them and not so much the policies that will benefit the people. You know, so they can lobby against insurance, they can lobby against Medicaid expansion, they can lobby against Medicare for all, right? Or at least including the oral health component into that, because they come in with big private equity dollars to do it. And all we have is, you know, me, you, Marcus, and Jessica coming in there, you know, and trying to advocate on behalf of the people. So
you come with me, we're gonna get some shit changed though. But go ahead.
Oh, I do have those numbers for you guys. I just want to give it. So in 2017, this is American Dental Education Association, which has great data. 2017, 295 African Americans graduated from dental school. Hispanic or Latino, 507. American Indian or Alaskan Native, 22. Asian, 1,499. Out of all graduates, 6,238.
Damn, that's messed up. So let me say this. As a non-doctor and dentist on here, you all been throwing around that P word a lot, that policy. So what I'm hearing as a solution is, first with these pipeline programs, and I'm talking to all you administrators and researchers out there, we got to get off our ass and learn about this dental stuff and start making sure these young Black sisters and brothers could take these Kaplan courses and everything. I know we do it for the MCAT. I know we do it for the GRE. And I'll admit, my lack of knowledge, not even knowing it was called the DAT. So now I'm going to put that on my portfolio in terms of what I'm going to advocate for when I'm out here, doing budgets and grants. I want to start paying for these dental people to get, these Black folks to get in dental school. And it starts, like Dr. Williams said, with the testing. These Kaplan courses, young people, aren't about just, I got to take this course. It teaches you how to take the course. You can study on your own, but it's a gimmick and a trick to this game, and we just want to help you. That's it. The second thing, here's a brother. Now, Dr. Williams said she does rural stuff, but this applies for her too if you want to reach out to her. Dr. Williams, Pat, went to Morehouse. It's a Black man, went to Morehouse, went to Harvard, got his MPH from UIC. We got to get off our butt and help them with research along with these other dentists. We have to be their advocates, just like we do in the medical profession. We understand doctors usually see patients for 11 to 13 minutes. So we come in as public health professionals and create these culturally specific messages, help write the grants, help come into clinics and do the research. We should be doing the same thing for the dental community, because once we do it, once we prove what's wrong, then we're able to give it to our other colleagues, our politicians, the good ones, and get stuff in the policy. We could set stuff up. If we prove, and we know it's right, but unfortunately, the world we live in, the white folks want to see it on paper. They want to see it through research. So we should be reaching out, figuring out, hey, Dr. Williams, she's in rural America. They have some of the same issues. Poor whites and poor Blacks have some of the same things. How can we help her prove her point to get better dental services for everybody? How can we help Dr. Smith? He's in Chicago. He's doing research with Black folks. I know, I assist him with it. Some wonderful things. There's no research out there. We got to support our people, and I'm speaking for Black people right now. We got to support our people and lean on our non-Black people to start throwing dollars behind this cause. Because if we don't, we are going to be messed up, man. And I don't want wooden teeth. You know what I'm saying? That's what I used to say when I was little. I'm just going to get wooden teeth. But I want my babies to have good teeth and their babies and so on. Because like Dr. Murray said, she didn't know about dental oral health. It was passed on to me. I passed it on to my kids. God willing, they survived, oral surgeries at 12 and 14 years old, having to go under the knife for eating too much candy. All I was taught was brush your teeth. And there was a debate whether you do it once or twice a day. Do you use floss?
Yeah.
Do I use baking soda and hydrogen peroxide? That's what my grandmother would give me. So we have to know what's out there in terms of natural remedies, dispelling the myths, educating our people, creating pipelines, and anything we could do just to assist the cause. So you all got me, man. I'm about to. I'm not saying I'm gonna go to the dentist more, but I'm gonna start going. But I'm about to start advocating for the shit a lot. Like for real, man. Like doctor. And I just want to say this too, Dr. Smith. On another level, if there were young people that that were interested, he'd always answer the call, tell me the process. So you all should be lucky to have this brother for real, man. You should be real lucky. I know I talk too much. We're running out of time, so I'm gonna go around and let everybody close out with something nice to say before I get on my soapbox and say what I really feel about these damn universities and how they play us. But I digress. Dr. Williams.
Yes. I will say thank you so much for allowing me to chat here. Like I was telling Dr. Smith, I was like, what are the topics? Because I could talk about this all day. Like I love I love educating people about proper oral health. I love, like I said, trying to get people into the field, trying to encourage young people to pursue dentistry if that is what they find is their dream, what they really want to do. We have a lot of work to do, but I'm excited. I'm hopeful. I think we can move in the right direction. We just got to keep the momentum. It's about policy, but it's also about really looking inside ourselves as a industry, but also just as a people, as your own self. You have to look inside yourself as well, and really try to work to improve the health of all people and through all policies. So again, thank you guys for allowing me to share.
Dr. Smith?
No, thanks for having me as well. It's always a pleasure to talk with you and Dr. Jessica. It's a pleasure to interact with you once again. For me to build off of what Jessica said, whenever we talk about policy, I'm under the belief that people make policies for people that they care about. And I'm also under the belief that you don't get to care about people you don't really know like that. So particularly when it comes to Black people, Hispanic people, white people, all people, we all have a context that defines our existence, that influences our decision making and how we just move about the earth. My challenge to everybody is just to build more relationships with people, right? Whether you're a clinician, and you don't quite understand why your patients may not value dental care or why they don't, where the anxiety comes from, get to know them a little bit, talk to them. When it comes to the research that we do, Marcus, I'm real big. Let's, if you don't know me, you might not even want me to ask you any questions, right? So relationships are huge. And I would just encourage everybody to exercise, especially the times that we're living in now, where you got red versus blue, white versus Black, and nobody can agree on anything, but I tell you what, the people who I can tend to disagree with and still be cool with at the end of the day are the people who I have the best relationships with, right? There's never any hard feelings whenever we disagree, and we tend to work well together and get things done. So I would leave people with that thought, just to try to focus on building more positive relationships. And I think we can all move the needle just a little bit closer to where we're trying to get.
Dr. Murray?
Well, I want to thank both of you for coming on this month. We'll be sure to have you back, and not only you, but other dentists, especially. I'm very interested in talking to some of the dental students. I do want to give one message, though. This is whatever month we're almost coming up on a year of COVID-19. Please do not underestimate the stress this puts on you and your family. And for those of us that interact with students, whether they're college students or third graders, don't underestimate the stress that they're under. So be a little gentle and kind, and remember, this is a major stressor for all of us at this moment.
And blessings to anybody that lost loved ones or a friend during COVID. And I'll just close by saying this. I'm glad to have you all on. I will say it's been quite enlightening for me as well to learn about dentistry and the things we could do. I'm excited, especially since Dr. Williams said she would love to talk to students. Maybe we could set something up in the near future where we could talk to graduate students and high school students and what they need to do, and you all could invite your colleagues. I'm excited to see about what research is going to come from the area. And just on a personal note, my wife is an AKA. My daughter plays golf for Howard, but she hasn't started. So I'm happy for the imagery that Kamal is bringing to the table for Black women. You got to start giving people their flowers when they're alive. We're going to have an exciting year next month. The third Wednesday, we're going to talk about medical mistrust and what's going on. We're going to talk about community engagement in the upcoming months. We're going to have people on here. And since I'm just giving flowers, I want to acknowledge the queen of community engagement, Dr. Tanya Roberson. She's a good person out of Governor State that you all should think about partnering with and doing things with, whoever's listening. And besides that, everything is all good. And next year, we'll just pray that the Bears and the Saints go further, man. You know, because I'm still depressed about the damn Bears. And then what's worse is the sorry team that beat us, they lost to Tom Brady the next week. Like, man. And then I forgot to say, too, acknowledge the one man behind the scenes, Andre Moore, because he takes care of everything for us. I know you all don't see us. So before we go, I just want to say it again. Thank you all, and thanks, Dre.
Yeah.